And this is, again, version 1.0. So for the current design, in terms of what scope of services, what are actually included in the episode cost. So the episode is triggered by, these are colonoscopy procedures, not sigmoidoscopies. It's triggered by any sort of colonoscopy, both diagnostic and screening, depending on the payers. There are obviously differences in that. And importantly, with primary or secondary diagnoses that require a colonoscopy. So some of them are listed here: colorectal bleeding, hemorrhoids, etc. The time frame of the episode for a diagnostic colonoscopy, the episode begins and includes related services 7 days prior to the procedure and concludes 30 days after the procedure. For screening colonoscopies, the episode begins at the day of the procedure. There's no pre-procedure window, so to speak. In terms of what's included in the period after the procedure, it's related services within 30 days, and there are inpatient readmissions within 30 days in line with CMS guidelines of readmissions that should not be included. There's a long list of things that would typically not, that would not be a readmission. On the second box here, you'll see it says patient exclusion. So as Bill mentioned before, there are many patients excluded. We will go through the list in more detail. This is one substantive area where we would really like your feedback as well. You'll see the first sub-dash here: patients with select comorbid conditions are excluded. There's an example here of IBD, some cancers, transplants, etc. And the way most of the comorbid exclusions work is the payers look back 365 days for that particular patient, also during the duration of the episode. If there are any codes in the claims data that indicate any of these comorbidities, those patients are not included. Those episodes are not included in the overall calculation of an average cost. There are some age restrictions here too. So patients younger than age 18 are excluded from the episode. And for the time being, with the commercial payers here and Medicaid, it's focused on patients age 64 and under. And there are other, business exclusions of if the patient is continuously enrolled, etc. I see a question.
So in a state in which there are a paucity of gastroenterologists and surgeons, the people capable of performing colonoscopy, and even fewer who take call, John or I could get a phone call 2 o'clock in the morning about a patient who comes in with a large, what ends up being a diverticular hemorrhage. Comes into their local hospital, and then we accept the patient for transfer and ultimately do the procedures on those patients, one of those procedures being a colonoscopy. Are we then liable for the costs at the prior institution, and are we identified as the principal person?
Bill, do you want to answer that?
Yeah. In the earlier slide, talk about emergency room presentations, acute bleeds. We excluded those on the outset.
All inpatient procedures, period, are excluded.
Yeah, inpatient care is
focused on the outpatient. Yes, thank you for
Fine.
for raising that.
Then scenario is they get discharged from their place, and then 2 days later they contact one of my faculty members or one of John's colleagues, and then get a colonoscopy. That still fits within the prior thing. Are they liable for those costs?
It's going to be costs related to the procedure. So if they were in for pneumonia, it's irrelevant.
No. If they were in for a bleed. If they were in for severe diarrhea. But we didn't have any contact with that patient. And that is in large part, the model of care at UAMS, certainly,
sure.
And I think at the other larger institutions in Little Rock. And if I don't have any ability to modify the way that those patients are managed prior to being seen by me, I don't want to have to assume those costs.
We are working through the process now, and because we had this discussion earlier about what is included in the pre-procedure period of time. We're going to take your comments and we'll get back to you. We're working on it as we speak. But no,
Well,
again,
thank you for that.
the bottom line is we want to make this a fair process. You're bringing up issues that will affect a small number of providers in a small number of patients, but your points you're making are valid and real, and we'll build that into the system and we'll try to account.
On episode exclusions, so as Bill mentioned before, the cost thresholds for the episode will be adjusted based on a few things. Risk factors, so renal failure, diabetes, there are a number of these that will actually adjust where the thresholds are. There's also going to be two different types of episodes here because of the different costs. So basically colonoscopies with additional procedures versus colonoscopies without additional procedures. Those have different costs, obviously, and so those would be separated out as another piece of the episode design. And also, as Bill mentioned before, only providers with at least 5 episodes per year would be eligible for gain sharing or for risk sharing under the episode. In terms of the quality metrics, the metrics required for gain sharing payment to be eligible for that shared savings, so to speak, there are 2 of them that have come up in various discussions. One is cecal intubation rate, and 2 is withdrawal time. And for these 2 in particular, these are not pieces of data that are currently available in payer administrative claims data for each given patient. We've heard feedback from different clinicians that it's still quite important to track this and as a quality metric to make sure there's kind of effective quality. What the payers will do here is office staff would not be asked to report kind of whether the CEQA was reached for every individual episode or every individual patient, but rather in aggregate across their patient panel, what was the percent for each of these 2, or what was the average withdrawal time?
And what we're going to do here, we want to encourage, since part of this is also building infrastructure, these are things that people down the road are going to be collecting anyway. We're going to say, to be eligible for gain sharing, we want you to collect it. We're going to set a very low bar, but the key thing is to get people into the procedure and the process of collecting information and reporting it, and then we can go from there.
There are 2 quality metrics listed here that are for reporting only. Perforation rate, and also the post-polypectomy and biopsy bleed rate. Those 2 will be reported to all principal accountable providers. And finally, for who the principal accountable provider will be for Medicaid, Medicaid has made a determination that it will be the primary provider that is actually performing the colonoscopy. The payers have to make these decisions separately, so Medicaid is announcing publicly that their selection of who the PAP would be.
And just to follow up also on the reporting metrics on perforation and post and the bleed rate, those are small incident events. So obviously, everybody can have one every now and then. And to tell you the truth, if you have a number of those, your average cost per case is going to become quite high. So we do capture, if you will, if you had a high frequency of those events, it's going to be in your average cost. On the other hand, it is worth tracking, and it's good for the system to at least say we're monitoring that kind of activity.
Finally, it's not listed on this page, but there are other technical things like episodes that are far too expensive or several standard deviations above the average would also be excluded. So things like that are not necessarily on a clinical basis, but those are taken into account as well. So let me just flip through a few more detail on these, on each of the 5 things I just walked through, and then we'll pause for some discussion. So on the following page, this is more graphically laying out the set of services that are included in the colonoscopy episode. We did discuss this just before, but you can see again for some of the episodes there will be a 7-day pre-procedure period. As Bill mentioned, the pre-procedure period across all the episodes is something that we've been discussing quite intently with feedback from many clinicians, and the episode will continue 30 days after the procedure. And you'll see that a range of related services are all included in calculating the cost of the episode, whether it's office visits, so preparatory visits, labs, imaging, diagnostic tests, all the professional claims for the procedure and for any other related services that are part of the episode. The inpatient or outpatient facility costs are included. related medication, then, as I mentioned, 30-day readmissions, but those readmissions have many exclusions based on what CMS has published as things that would not be considered related to the episode. And so this is the set of services and the time duration that's included. If you flip to the following page, the following 2 pages list out the clinical exclusions that the payers are applying to the episode. So you'll see there's the age restriction on the left-hand side on page 23. So younger than 18, over 64, those patients are excluded from the episode. These are outpatient colonoscopies only. For colonoscopies that originate for patients starting in the ED or in the inpatient setting, those are also not included in this episode. You'll see here a list, I won't read all of these, but a list of major medical procedures, complications, other chronic diseases, etc. All of these, if any of these codes kind of appeared in the 365-day window prior to the procedure, prior to the episode, or during the duration of the episode, those patients would also be flagged for an exclusion. And then on this finally, if you flip to the next page, there are a set of cancers and other clinical exclusions. Again, I won't read them all, that are also being applied to exclude patients from the episode. I'll just go through 2 more slides here before pausing. On the page 25, the quality metrics, we mentioned this already, but cecal intubation rate, withdrawal time, those are going to be aggregate metrics reported through a portal. The bottom 2 are things that are trackable through the administrative claims data, so providers would not need to report anything extra for that.
What about post-procedure follow-up? For example, a patient comes in, you have a colonoscopy, and he had a polyp. Is that included in the overall?
Thank you.
Or does it have to be within 30 days follow-up? I mean, sometimes you just can't do it.
Great. Thank you for the question. Any other questions, comments? And again, let me encourage the outlying sites to comment as well. I know it's sometimes harder without being in the room. We have a question here in the room.
Yes, on like they were saying, we normally do colonoscopies. We have a recall list. We may start making our patients appointments, some of them because of cardiac clearance workups, things like that. They may be scheduled and seen 30 days before we do their scope because we're getting cardiac clearance, this, that, and the other, making sure we can take them off their Coumadin, these sort of things. We do their scopes. We always have them come back and see us. Whether we find a polyp or we find diverticulosis or whatever. Sometimes their schedule, because they've had workups or they've had this and that, they don't want to take off work, we may not see them for 30 days.
Right.
It may be after that. So I hear this from others. It's not just one thing. The other thing is when they, in this 7 days or this amount, if we do send this patient to have cardiac clearance, we've got one right now. The doctor decided that he's going to wear a heart monitor. He had an EKG, he had a stress test, he had all these. Is that going to be all involved in that amount, in our cost?
We have debated this time and time again across many of the episodes. There's essentially 2 or 3 flavors for how you think about this. You could say, all the pre-procedure stuff, it's too hard to figure out exactly what that is. Sometimes the principal accountable provider had direct control. Sometimes, a patient was referred to them, and so there were tests and diagnostics done that are costly, maybe weren't necessary, but I, as the principal accountable provider, had no say to that. So one option is just to say it's too difficult to figure that out. We're not going to look at the pre-procedure costs at all. Another option is to say, well, it's not going to be perfect, but let's figure out some set of the pre-procedural costs that reasonably a principal accountable provider really could influence and shape, and that there's real value in managing. And then you can go more broadly than that. And as Bill mentioned, the tension is always, there's some cases where the PAP, the principal accountable provider, today has influence over the stuff that's happening before. In some cases today, they don't have influence, and maybe they might want to. But so those are some of the things that, as a group, we've been thinking through.